Good afternoon and welcome to the OR Today webinar series. We're excited to have over 300 registered attendees for today's webinar. Just a reminder to save the date for our 5th annual OR Today Live Surgical Conference, which will take place on August 18th to 20th at the Palms Casino Resort and Spa in Las Vegas. Join us to discover new opportunities, broaden your knowledge and exchange ideas. Registration is now open, so for more information, please visit ortodaylive.com. Okay, let's kick off today's webinar by giving an OR Today Live surprise pack to the attendee that can tell me the answer to the following trivia question. April is National Pecan Month. Which state produces the most pecans? Answer now using the questions feature on your dashboard. While you're answering, I want to remind you today's webinar is eligible for one continuing education hour. To obtain your certificate, you must complete the post-webinar survey, which will appear immediately on your screen at the end of today's call. One lucky attendee will have the opportunity to win an Amazon gift card courtesy of OR Today just for completing the survey. Okay, and let's see who is the winner of our surprise pack, and it is Christy Edmonds. Well done, Christy. The correct answer is Georgia, of course. OR Today would like to thank our sponsor, Rep Scrubs. Rep Scrubs offers vendor management and cost reduction solutions. The Rep Scrubs program provides assurance that every vendor entering a sterile department is wearing clean, prepackaged disposable polypropylene scrubs dispensed on site, while shifting the expense of providing those scrubs back to the vendor. The Rep Scrubs system offers hospitals a unique way of improving infection, prevention, and adherence to regulatory guidelines, reducing costs and enabling hospitals to better control and manage vendor access. For more information, visit repscrubs.com. Our presenter today is Deborah Hamrick, Executive Director of Perioperative Services at Grady Health System here in Georgia. Deborah, you may begin whenever you're ready.
Thank you, Erica. Thank you, everyone, for joining in on your busy afternoon for the webinar. And today we're going to talk about and focus in on who's who in the OR Zoo. And it was really quite funny this morning because I was at the front desk here at Grady, and one of my nurses came up and she said, "It's a zoo today." And I said, "Yes, it is." Let me tell you a little bit about Grady. We are a 700-plus bed hospital in Atlanta, Georgia. We're a level 1 trauma center, nationally recognized, and we serve primarily DeKalb and Fulton County, and we're a safety net hospital. However, our level 1 trauma center, we see patients from all over the world here at Grady through our trauma service. So today, the Who's Who in the OR Zoo actually got started from looking at what our nurses were saying about what's going on in our operating rooms here at Grady. We are affiliated with 2 schools of medicine here at Grady, which is a little bit unusual. So we have residents, medical students from all over the city of Atlanta here in our operating room. And we are 18-plus beds on one floor and 4-plus beds on another floor, where we have 4 ORs on another floor. So intraoperative patient care, we all know that nurses really do like to take care of patients. But in this day and time, we're seeing that little bitty steps nurses are having to take little bitty steps back from their focus of patient care because there's a lot of competing demands out there for their time and attention in the OR on task and managing the environment that sometimes actually is bringing them back from their focus of where they want to be patient care. So looking at this, looking at the situation in here at Grady, what could be managed prior to our nurses getting in the OR? What can we do better for them? What distractions can we try to manage for them so that their patients are not getting lost or they're getting pulled back little by little from the patient care that they should be delivering and want to deliver? So patient safety really is our main focus here at Grady at this point. And we are putting a huge effort towards getting that focus back onto intraoperative patient care and getting our nurses back to where they want to be. For example, one of my nurses was talking to me not too long ago about just not being able to be there at the bedside and holding that hand when that patient goes to sleep, which is very important to every patient going to sleep, because as we all know, if you're 6'5" and 200 pounds, you're still going to squeeze someone's hand as you start to go to sleep. So when we look at some of our interoperative team distractions, we look at complex technologies, we look at regulatory requirements, documentation requirements, charges, inventory controls, phones, all of those things. So when we look at, back to complex technologies, for example, our robots. Used 2 years ago, we had laparoscopic towers, and that was it. But now we have nurses who are putting these robots together, getting ready for the cases. We have neuro cases whose technology for those is tremendous. Then we look at our regulatory requirements, and we're asking our nurses in the rooms to make sure that we look at who's in the room. Do those physicians, do those medical students, who has credentials to be there? We have documentation requirements. We have electronic medical records. And the staff here really loves when we go on downtime because they like that patient charting on paper a little bit better than EMR because it's less time consuming for them. Then we ask the business side, the nurses, let's make sure your charges are correct. Are your implants documented correctly? Phones, how many phones do our nurses manage in the OR? Our physicians, our residents all have phones. We're asking our nurses to coordinate the dance between all of anesthesia, x-ray, vendors, SPD. Do we have the trays we need? Is the vendor correct? Asking them to coordinate all these activities. And some of our hospital processes outside of the OR, such as pathology, sometimes can be those processes being daunting for our nurses to get that right. The floors getting our patients ready, all of those outside competing demands. Here at Grady, some of that's law enforcement. We have a huge population of trauma, so we see law enforcement here a lot. And all of those law enforcement, each county has a different process, and our nurses are asked to also in the rooms to navigate that. We have students. We have RN students. We have allied health students. We have all of these folks coming in to our OR rooms, and sometimes we can count and have counted up to 12 people in the room. We've asked our circulating nurses to make sure that our observation patients have been vetted through processing, through medical staff. We've asked instructors coming in to talk to our nurses in the room about evaluating the students that were in there. It's just a huge demand on their time at many points along the way with our patients. We have novice surgeons, we have residents, and we have medical students. And a lot of times we're not quite sure where our medical students are. They'll be asked, hey, can they scrub today? Have they ever been taught? Do they know what they're doing? And we've asked our nurses to take care of that as well. And our visiting surgeons here at Grady, we have a lot of research going on. So we have visiting surgeons from all over the country coming in. We have proctors coming in. And that takes work on our circulating nurses, asking them, giving them the information, and then asking them to make sure that these individuals are within their practice parameters here at Grady once they get here. And then, of course, we have a huge representative of sales reps here. We do a lot of innovative type procedures. We do a lot of research. We do a wonderful amount of new procedures that are cutting edge. And again, it's all around research, and we also are asking our nurses to also take care of that as well, which takes them, when you look at what their time limits are and where their patients are, we are constantly and they feel that we're almost constantly asking them to coordinate everything outside of the patient hands-on where they really want to be. We have many, as everyone else does, we have many staffing opportunities at Grady, as I'm sure everyone else has as well. It's very rare that here in Atlanta we see an experienced OR nurse, and when we do, we have to grab them up because we have many hospitals competing for that same nurse, experienced operating room nurse. And we really do like, as I'm sure everyone does, those operating nurses have that critical thinking skills that can actually navigate some of the difficult situations that they will experience. We do grow, as most hospitals do, we do have to grow our own staff, and that takes 6 to 9 months to get someone who is independent to be on their own. We do use AORN, and we do partnership with some of our universities in the Atlanta area. We have 4 of them that we partnership with for residency programs. So that's a very wonderful thing that we have in Atlanta as far as a resource to try to help grow our own. Can we keep up with demand for experienced OR nurses? We cannot. We still struggle with that, and it's very costly also for Atlanta, in Atlanta to do that. I'm sure it is everywhere else. We have ancillary roles like SSTs, which are our support techs. We have our anesthesia techs, and again, we have to home grow them because we don't have any training places here in Atlanta. So, and as always, our nurses in the room, when we have new ATAs and new SSTs, they partnership with our nurses, circulating nurses in the room, to learn about equipment, to learn about actually OR techniques. And again, that brings them one step back from that patient. We have ancillary roles, we have agencies. We definitely have a higher rate of agency than we wish we did here at Grady. We're trying to get through that demand. But again, it is, part of the situation that we're in right now. As we know, building specialty teams, our physicians love specialty teams, as any physician does. You have to grow those teams and educate those teams, and that is, again, another competition for the nurses' attention to the patient, having all the new staff members in those rooms to work with that nurse while she's attending to the patient. We have surgeon participation as another opportunity. We're trying, as most other hospitals are, to very much get our surgeons involved in the orientation and the training of our new staff members. It is working well here at Grady. We're not where we want to be, but again, we're still working towards that point so that we can have that in place and we can get through these staffing opportunities and get the nurses more focused on patient care and less focused on training everyone. And that's one of the places we're at now in trying to manage our nurses' competing opportunities is with our extra demands on orientation for our staff, and again, taking that a step back from patient care. Their preceptors are getting a little bit burnt out with this, and again, that's one of the competing demands for that true hands-on patient care in the room. One of the challenges that we're finding here, and I'm sure and at other places, is with the critical thinking skills. And we all know that we use the term time at the table, and the more time you spend in the operating room, the more you develop those critical thinking skills and being able to navigate some of the potential problems that you face during patient care and during managing those competing requirements for your time, for circulating the nurse time. So those are the kind of things that we're trying to manage here in Grady so that our patients can get the best care that they get and we can focus on retaining our patients. Now, we all know that there's nurses want to focus on patient care, and we're demanding more and more time away from that patient care and managing these other competing opportunities. Nurses want to focus on patients. The financial impact of having nurses doing orientation it takes time to motivate staff. They're out of staffing. The intraoperative role is a real-time role. So not only is that nurse taking care of the patient, but they're also taking care of their orientee as a preceptor. We use educators, preceptors, and clinical experts in our ORs, but we all know that those are soft costs, and it's one of the places that's hard to justify when you're justifying FTEs to administration that you need these costs for retention of these nurses. Company-based skill sets, we all are very much aware that those are very critical to our nurses in the operating room and to our other staff as well. that participate in our patient care. For example, residents, interns, medical students, and fellows. I use a robotic program as a perfect example. We've spent a lot of time working with that team and getting PA educators in to help that team manage those opportunities for ensuring that education is done, skill sets are done, practice is done on the simulator, so that our nurses, when it comes to time to do those cases, are not looking back to make sure that this person has this skill set, this person has that. That was one of our main voices that we heard from our nursing staff, was they were managing who could do this case rather than managing the case. And again, we have two school affiliations, and one is Emory and one is Morehouse. So we have both sets of residents and both sets of medical students, and those are all at different stages in their professional development as well. So that's one of our items that our nurses must also manage when they have those individuals in the room. We have auxiliary skill sets for our support staff. It's very difficult to get our support staff in and get them trained, teaching them what all the equipment is, where it goes, what you need to do when you bring it to you. So we're asking them to be a jack of all trades, but they have to learn that. And again, how do they learn? With some education, but also in real time in the room with the nurses. We all know that there's that one person in our OR that knows, that support staff that knows all of the equipment, that knows everything about it. And how do you get that from their brain to a piece of paper to a competency assessment? And that's a big question that we're working with as well right now to try to make that happen for our surgical support team. All of the demands that I've talked about so far here at Grady in our experience is one of the I want to say not dissatisfied, but one of the concerns that our nurses have in how to get back to actually focusing on the patient. So from a perspective of what can we do to help our nurses manage their patients better, and what can we do as a leadership team in an institution to manage some of these competing priorities prior to that that patient getting into the room. And who are our patients at Grady? How do we match our nurses and our patients together? And what are we trying to manage as far as the environment so that they can focus on this high acuity set of patients? Our patients at Grady are very high acuity. Our BMI here at Grady is an average of 39.2. Our patients are diabetic. They have a lot of comorbidities. We have a lot of specific technologies that we use here at Grady to manage the disease processes that we see, and a lot of especially our traumas, and especially our staff skill sets within trauma here at Grady. Our nurses usually, our trauma team is those nurses that have cardiac experience, they have vascular experience, and they've been at Grady at least 18 to 24 months and have participated in the trauma cases that we give here. It's not unusual for us to see at Grady. We'll see maybe 5. A good day is 1 or 2 traumas, gunshot wounds. A more bad day or a little bit more challenging is recently we've had up to 6 or 7 a day. So again, that's feeding into our regular schedule, but yet it's one of the things that we do very, very well here at Grady, and our nursing staff is phenomenal at it at Grady. So our nurses really want to do no harm to our patients in the operating room. We don't want our patients to leave with an infection, and we don't want any intraoperative injuries. And that's what our goal is for our nurses in taking care of our patients, to manage the environment, manage the patient as a team member, and send our patients out with no harm, no intraoperative injuries due to positioning or anything else, and no infection. And as we look back and use the very simplistic, infection is pretty much equal to the number of microbes times the virulence over the host factors. And in the operating room, there's really nothing that we can do about the virulence of an organism. We know that we have multi-drug resistant bacteria in every hospital. We know that there's a yeast infection that's out there now that we have to be aware of. And the host factors, we've already talked about. Our patients come to us very much not in a healthy state. What we can control and what nurses can control and the team can control is the number of microbes that enter our patient's environment. And we control that by, of course, aseptic technique and, of course, controlling environmental cleaning and also traffic patterns, everything that goes in with that aseptic technique. In working with our culture here at Grady, how do we change and where do we want to go? Where do we want to go with patient safety and our patient focus? And we started that here. We started enterprise-wide with our Grady 2.0, which is safety first, meet expectations, and then exceed expectations. So where did our OR team and where did our OR team staff want to start in the very beginning? And what they choose to start to look at was what's controllable, what are the people, places, and things that are impacting us being pulled further and further away from the patient. What process can we control prior to the operating room? So we asked the staff, sat around across a table, we talked about it, and the whole idea was for our team, those teams, including our surgeons, our entire surgical team, including anesthesia, to go back to basics, to look at aseptic technique, to look at controllable factors that we can control, to take noise out of the chaos or the zoo-ness out of the OR room itself and bring it back to a very controllable environment where the nurses in the room are able to focus more on patient care and less on controlling things that we've asked them to control. So we know that there are many competing priorities for the nurses' time. The largest one that we faced here at the time was who are all these people and what can they do? Why are they here? What is their main focus and should they be here? We had some red flags that showed us that we needed to really focus in on the limiting of the number of people in our operating room and making sure that it met the needs of the patient and did not exceed what that patient needed. We talked about it. We took the OR committee and we decided to look at limiting the number of people in the operating room. Did a study and we had sometimes 14, 15 people in the room before, as you went through reps, you went through medical students, you went through interns, and you went through this, you went through that, and just students, and there's just too many people in the room. While keeping our mission of education here at Grady, of course, with all of our universities that we partner with and all of our medical schools that we partner with, we wanted to match what the resources were, what the demands were for the patient, and what resources that our nurses had and what they're competing with to stay at that patient's bedside. So what we did and started out with was identifying those roles with physical identifiers and standardizing our roles in the OR. Who does what, when should they be there, what don't they do, and what are they credentialed to do, but most importantly, what is the help that the nurses need to control the number of people before they ever even reached their operating room. So how we started out was looking at how do we distinguish who's who and what's who and who's coming and who's going. At the time, everyone wore green scrubs that came into our operating room, everyone. There was our little tags are small enough, our little name tags, that you really can't see who's who. I mean, you have to be very close to someone. So we had some red flags that came up, and we looked at, okay, so what was the deciding factor for this? And what was the really root cause for when we had that problem of who's who in the OR? So when we looked at a situation, after the root cause, it was decided no one really knew who the circulator was in the room at that time. Not being able to distinguish who was in charge of the room, who was the decision maker, who was the one that was the air traffic controller, and who was the one in charge of the patient flow, Who was the one that was watching out for the sterile field? There was always a circulator in the room, but not easily distinguishable from everyone else. So what we did was we said, okay, circulators in the room are now going to wear the flowered or the flash bouffant. So now the only person in the ORs are the circulators that wear these hats. So when you see a hat of either the splash or it's flags for the guys, and sometimes that differs a little bit. But then you know in that room, that is the person, that is the circulator who is in charge of that room. It made a big difference. There was no question anymore. If we had a resident that was here from first time from one of the other hospitals, and he knew that, or she knew that that was the circulator in the room, and that's when they needed to talk to, because he or she was the one in charge of the. I keep saying he or she was in charge of that room, and that made a huge difference. Also in the confidence of our circulating nurses, because now they were officially and visually given that I don't want to use the word power, but that's exactly what it was, to run that room. We took our students. They also wore green scrubs, and we also had a red flag issue about a student once. So how can we distinguish students? So talked with the risk management in the hospital, and we all decided that we're going to put them in brown scrubs. So now any student, whether it be a medical student, whether it be a nursing student, whether it be a radiology student, they are all in brown scrubs when they come into the operating room. So you know if you see someone in brown scrubs that they're not really a decision maker in the process and care of that patient. And that has been a huge positive factor for our nursing staff, because now they can distinguish our residents and our interns from our students of any type, whether it be nursing, again, medical, or any of those other variabilities as well. We took it a step further, and we have a lot of visiting surgeons for proctors. We have surgeons for research. We have a lot of international surgeons coming. So all of our visitors outside of students and reps wear yellow. So when the nurses see someone in yellow in the back, they know that visitor has been through the credentialing process through medical staff, and they are allowed to be there. And that is actually huge, because everyone being in green previously, it wasn't really clear who was who and what was who. And to get everyone in the electronic medical record was a challenge for that circulating nurse. And again, we've helped that circulating nurse know who is who and what their role is by virtually just looking at them. They know whether they're a student or whether they're a visitor. All residents and all fellows actually from both schools of medicine actually wear the green scrubs, so we know that they are decision makers in that patient's care. We had the opportunity to take it a step further, and I just want to share with you one of the instances that kind of brought this to a head is all of our vendors wore green scrubs prior to a little over a year and a half ago. And I actually followed a vendor in the green scrubs from the parking deck. He was in front of the hospital, followed him in, and just followed him upstairs. And he went right in, put on a red hat, and went straight to the back. Asked him if he was going to change his scrub suit, and of course said no. And at that time, our process for vendors was they came into the front office. They would sign a sheet of paper. We would take their driver's license, believe it or not, put it in a drawer, walk them to the vending machine, get them a set of scrubs, come back. They would go change their scrubs, and at the end of the day, they would bring their scrubs back. We'd give them back their driver's license, and then we would deposit those scrubs into the scrubette, which was a time-consuming effort. So we made the decision to put our vendors in disposable scrubs using rep scrubs, and that was a very good decision. We have vendor mates here as well, and I bring that up because we're going to talk about that later. But we have vendor mate as well, so reps are expected to log into vendor mate and then get their rep scrubs, get changed, and go back into the room. One of the biggest satisfiers for our nurses was when they see their reps come in, They're in these beautiful blue disposable scrubs with their name tattooed on their scrub directly across their chest, and they know exactly who's there, and they know exactly what their role is, and it just makes it so much easier for them trying to find out who's who and who's what and who's doing what. So that was a very positive move for us. Other opportunities that we've seen in working with managing our people coming into our operating room is looking at competency assessments for all of our students. We're in the process of a no-fly zone, which we've reached out to our medical schools and working together with them to put a training program in for all medical students. So if the medical students don't come in with a dot on their badge, then they're not allowed to scrub in, because no longer can we pull our nurses and our techs away to educate in real time people how to scrub and put on a gown and glove. It's just not going to work. Our visitor process has been really, really hardwired. Now our visitor process, like our visiting surgeons, do not get yellow scrubs until they've been through the process, so nurses no longer have to worry about that. We have flight boards now in the room that has all of the members of the team on it. So if a member of the team comes in the room, they have to put their name on the board and what their role is, and it's made it so much nicer for our nursing staff to know who's who and not have to pull the information or figure out who's who, and again, take that time away from patient care to do that process. And then staff education has been phenomenal. We've educated our staff over and over on these roles and responsibilities. Our distinguishable hats and brown scrubs and yellow scrubs are in our orientation process with our new nurses and new techs, so that's hardwired. And we will continue our staff education as far as residents and medical students as we continue onward. So we've managed our traffic pattern and people prior to patient care, and that's been our focus as we begin the whole journey of getting our nurses back to being able to focus more of their time on the patient intraoperative care. So that's really a huge nursing satisfier, and they're right along with us on this journey. So I've been asked, when we first started looking at the disposable scrub for our vendors, many questions came up about why are you doing this? It is very important that we look at what our cost was. We were spending around $128,000 yearly cost for scrubs. We've actually decreased that since we put in the rep scrubs machine. 73% of all our issued scrubs that we previously issued prior to implementation of rep scrubs, 73% of those issues went to vendors. We looked at our costs when we started to justify the rep scrubs program. We looked at our costs and actually took a stopwatch to how long it took us to process a rep for his scrubs, and it took us about 6 minutes. So when you took the time of my time as the executive director, the business manager, or the administrative assistant, we just averaged a little bit of mine in the business manager's time, because we also were in the office, so whenever it came in, we would, of course, make everyone available scrubs. So it was either the residents, the vendors, or whoever came through. It averaged out to about $32,000 a year we were spending just in the morning and evening distributing scrubs to the vendors that came to Grady. And I won't even mention the time that we lost a driver's license and had to come back in the evening to give a vendor back his driver's license. So we were out of that liability as well. That was not a good thing. We have a good handle now of legal infection and control. We are controlling those scrubs, those vendor scrubs coming into our operating room from other hospitals. I would just share that as we're implementing this process, We were about a week into rep scrubs, and I had one of our vendors came in, and he was in green scrubs with a red hat on, and I asked him where he got his scrubs, and he said from that machine. And I said, no, you didn't, because we're not distributing from that machine anymore. No, I was up the street, and he told me the name of the hospital. It was 3 blocks away, and I just came from there. And he was ready to walk straight back into the operating room. So infection control is really, really, we're getting a handle on that with the vendor scrubs coming in from the outside. Honestly, we're still working on other roles like surgeons and residents, but we're trying to manage that as well in a much more efficient manner. Regulatory compliance. I cannot mention how wonderful we are now in our Joint Commission survey time here at Grady, and I'm able to pull a list every day of who comes into the operating room through rep scrubs, and I look at it in the morning. It takes me about 5 seconds to look at it and see who's here. The front desk also has access to who's signed in through rep scrubs. We've been able to, what I do is I look at it in the morning and go out and find 1 or 2 people and ask them why they're here, and we'll talk about that later. But I've seen some really dramatic decreases in vendors coming here just to be able to come and sell their product and do those kind of things. In contract management, we are very much now into contract management of our vendors, and as Periop Exec Director, I have 14 contracts that I manage, and all those have KPIs related to vendors and sales, their sales forces. And what I'm using now is rep scrubs to be able to validate that, number one, they're compliant with the scrub suit process, but number 2 is that they're here for a patient, and that I don't have people back in the operating room who are not here to facilitate a surgery and help a surgeon with some sort of piece of equipment or implants that they're using. So that's been absolutely a wonderful tool for me as well. Safety-wise, our staff is able to now make sure that vendors are identified and they're not opening implants onto the sterile field, and they're maintaining their distance, and that they're there for that patient, and then that they're gone at the end of that procedure for that patient, or when they're no longer needed in that operating room. And the rep scrub also gives us an immediate identification of who's who, which vendor's going back, and why they're there. It's been absolutely phenomenal to see the staff response here to this program for our vendors. It was so, I don't want to say aggressive, but our staff was so absolutely grateful for it that it took us only about a week maybe to implement it. But even after that, if a rep got back who was not here for that first week in initiation, he was literally, he or she was escorted out of the OR to that vending machine and told what to do. So the staff is really, really, really into this program, and they've actually been the drivers for it, and it would not have been successful if they had not been so thankful that this program is here. Our staff always let the surgeons know that the rep scrubs was not going to go away. There was 1 or 2 pushbacks, and we'll talk about that later. And the staff actually told them, and this is a quote from one of my surgeons, said, "She told me to get over it. It's not going away." I said, "Yeah, she's pretty much right." So it was just a phenomenal response by our staff, and I just can't say how much that working with the staff and working with the vendor-made system, and also working with our rep scrub vendor and sales reps, they were just phenomenal in getting this program out of way. And I also want to show you one of the things that we have not had to do was we had Scrub Amnesty Day here at Grady last year in May. What we asked was, okay, if you promise to bring your scrubs back, because we were actually, this was 1970. Actually, we were about 150,000 to third quarter that we were fixing to have to buy new scrubs with. And we put out a Scrub Amnesty Day, and we gave cookies away for anyone who brought in scrubs they might have at home. And interestingly enough, we had one surgeon who brought 3 13-gallon bags of trash bags full of scrubs that he collected over the past 4 years back to Grady to be put into our inventory system again. And we also had a huge response for it. So we did that, I think, the last time in 2018. We started in 17 and did one in 2018. And our spend on scrubs has gone way down, not only as a result of vendor scrubs, but I think also as a result of the emphasis that we're putting on them in traffic patterns in the operating room and keeping the number of people down in the room and making sure that everyone adheres to the policy. So I think that's great, and that's where we're at with that. Implementation. The implementation was, it didn't take but maybe a week. I think we spent a week implementing the program. It went, I would give it a record of about 95% smooth. We did have a little bit of pushback, but there was a lot of homework that I did prior to getting the plan here, getting the rep scrub compliance here, the machine here. So what I did was had minor discussions one-on-one with our infection control officer, our compliance department, risk management, our chief medical officer, and our chief operating officer. And we had those chit-chats and discussions over about a 2-month period. And our infection control coordinator, Dr. Gonum, was very, very much for the program, and of course for infection control reasons. Compliance loved the program because I was able to demonstrate that I could pull a list of who was in the operating room, what vendor was back there, and I could look at who was here, why they were here, and manage that from patient safety, also from a HIPAA compliance as well. Risk management was very much on board because of the risk to the patient, and of course our chief medical officer and COO had a discussion with the perioperative leaders in the department who were very much on board. The team leaders were very instrumental in pushing it to the staff members. The director at the time who was here, she was very much involved in the decision, and the staff from the very beginning liked the topic of how we were going to move forward with limiting not just the reps, but everyone in the room with the color of the hat, with the scrub suits, and those kind of physical identifiers for each one of those roles. Key surgeons, our informal leaders, a couple of our orthopedic surgeons were a little bit hesitant in the beginning, but did come around. Our informal leaders as our surgeons, our general surgeons and trauma surgeons were very much also very supportive of the initiation. Then after those discussions and that homework taking about maybe 2 months, took it to the OR committee, which was then approved and supported with a couple of little one naysayer, but was supported, and then took to the hospital quality committee, who just absolutely loved it, supported it, and blessed it, and then we moved forward with the contract. I would have to say that our true success with this program was because the infection control, compliance, and risk were all aware and supported before we went, what I call up to the C-suite, to have that discussion. There was minimal pushback from our surgeons. We did get some vendor pushback. We contacted those vendors one up, and we talked either you're compliant or you have to go. There was a couple instances where I did have to go a little bit further up the food chain and actually contacted the corporate compliance officers at the company, and then very quickly got a phone call that those particular vendors would love to be part of the Rep Scrubs program. That whole process and those little hiccups took about 3 or 4 days. We did a lot of advertising to the reps. We had a go live, and on our go live day, leaders were available. We had chit chats with our vendors. We were prepared for any pushback, but we also stood totally firm in where we were heading with this program and what we wanted it to accomplish. Our staff was totally engaged. They loved it. We had our nurses telling everybody where the scrub machine was and how to get there and how to sign it up, and they had to go do it, and that's pretty much what happened. What we're looking at next We have some metrics that we look at. We've able to be able to document. We've decreased our total vendor traffic by 43% per week. And how we got that was looking at the number of scrubs that we, at a particular point in time, that we delivered through our signing system versus what was going through rep scrubs. And what I heard mostly was, I'm not paying that money to go back there and talk to him. So, again, very much stopped some of the unnecessary traffic into the operating room. Our MedApproved process, which is where we get our vendors asked to bring new items into the hospital, dropped 32%, mainly because we decreased their ability to go back and sell to our surgeons while they were in the operating room. We decreased our administration costs by our linen room by $18,250 estimated since implementation, because they no longer have to fill our scrub machines as many times as they did. We've looked at our documentation of our vendors and our EMR, and the compliance has increased. Our sales opportunities have also decreased inside the operating rooms. We have the ability to spot check purpose of a visit, which means that looking at who's here in the morning, going and finding why they're here. We've looked at vendor reports for vendor activities for regulatory compliance. I get a Rep Scrubs does a wonderful weekly report that you can see who's here, who's been here. And honestly, we've seen where we've had double dipping by reps who would bring in someone else and use the same number. So within a minute, you have the same person here twice. So we've worked through that, and we no longer have that as an issue. Our vendor traffic has also been reduced in SPD, meaning that they don't have open access because they're not in scrubs, and they do not want to go downstairs and purchase scrubs just to go downstairs. So that's been fantastic. And we've also now are looking at, and we just began looking at audit compliance with VendorMate. So looking at if you're in direct scrubs, then are you also in our VendorMate system, because they're totally separate from each other. And we're working with our compliance with our vendors on that as well. So we are making headway with that. What the word that's gotten out is they're watching. So our vendors are very much aware now that the whole team, the entire OR, is watching who's here, why they're here, and what they're doing here, which has been a great help to our nurses in not having to manage that piece of it anymore and can get them back to patient care. We also are using our Rep Scrubs metrics for our contract management KPIs, looking at the compliance, look at the compliance in Rep Scrubs versus VendorMate, regulatory compliance with VendorMate, making sure that all three of those are in alignment. I use Rep Scrubs as an evaluation tool for our vendors to make sure that they are in compliance with that. And I'll just give you an example. Went down to down the street, we have a little mart where people can go eat lunch, and one of the vendors was down there in his VendorMate scrubs, so he had to take them off and throw them away there. He had his other scrubs underneath it. So making sure that they're in compliance with our scrub retire policy. We do issue and have issued letters of reprimand for not being in compliance with either VendorMate and or Rep Scrubs, and implementing this quarter a vendor breakfast at 6:30 in the morning, where we have every vendor that does business here in our operating room to come together at 6:30 in the morning, and we're going to lay out the expectations, including the new contract management piece of it. And this will be mandatory to have one person from your company at least there to continue doing business here at Grady. In summary, I'd just like to say that one of our biggest opportunities for our nurses to have a little peace of mind and being able to say, yes, I don't have to worry about that anymore, is being able to manage our vendors, our students, our visiting physicians, and our roles in the operating room, and taking that piece away from them that they don't have to worry about anymore, and they can take a little few steps closer back to that patient care at the bedside. This is just the beginning for us in managing their time and their responsibilities, and what they don't need to manage, what can be done differently, what processes can be done differently to help structure and hardwire the perioperative philosophy that AORN has of total patient care, and getting them back to where they can hold that hand, They can help anesthesia be there for them, and they can get away from the unnecessary demands that are taking that time away from their patients. Thank you very much.
That's great. Thank you so much, Deborah. We've got a couple of questions here before we wrap up. Physicians are the most difficult to convince without any data. What is your solution to getting them to support this?
The data with the physicians?
Yeah.
Yes. Knowing that, what I purposely did was skirt around the physicians before I brought this process to them, in that talk to infection control, talk to risk management, talk to compliance, so that we are all as a united front that this is a good program, because number one, you know who's in your operating room, you can justify why that vendor is there, why they should not be there, and that they're in compliance with the scrub suit attire policy and in compliance with the infection control policies within the hospital. Again, got the question, where's the data that says a scrub suit contributes to infection? I mean, we're dealing with that right now as well. And the question is, it says it's not correlated. It all goes down to the controllable factors. And if you keep in mind the very rudimentary, infection is equal to the number of microbes times the virulence divided by the host factors, our whole reason for being in the operating room, our whole reason for being in an aseptic environment and practicing those principles is to decrease the number of microbes. That's what we can control. We really can't control the virulence, and we really can't control the host factors. We can try to maximize our patients' health before they get here, but we all know that that's not. You're still going to have your diabetics that show up with a 450 blood sugar in the morning of surgery, and you're going to get it down to 150, and you know at the end of it when they go home, they're going to go right back 100, probably 600 at that point because of stress. But the one thing that we can control is the number of microbes that we introduce into the environment, and we clean the rooms, we sterilize instruments, we do all of that to control it because they're controllable factors. And that's what aseptic technique is all about. And you really can't argue that. That's the bottom line. And that's my approach with it.
Okay, that's great. We've got time for one more question. Is there any data showing a decrease in SSIs yet?
It's again an SSI. You can't correlate scrub suits to an SSI, but it's a controllable factor. What we are seeing is that we are hitting the infection control piece of it and the SSI piece of it from a very structured platform with our quality committee within surgical services. We have the audits about aseptic technique that we're looking at. Anytime we have that quality piece going on, and part of that is scrub suit attire. Again, the trip to the market, saw a surgeon and a couple fellows are out down there, and some of my staff members in their scrub suit, and that's not acceptable. That's a controllable factor. So we're addressing that, addressing the fingernails, addressing antibiotics within the time frame and appropriate antibiotics, temperature in the room, all of those skip measures that we know decrease SSI, but also looking at postoperatively. Our leaders go out to the floors and look at our in-house post-op patients and see if they're using their incidence spirometer, if they still are up and walking, those kind of things. We just, we're making sure we're doing a CHG bath. If we have a patient that gets into the OR, and we do have a large homeless population, we're going to stop the process and do a little bath there in the OR. So that's how we're looking at decreasing those SSIs, but I don't ever envision that there's going to be a way to say, scrub attire decrease SSI, because it's such a variety of components that go into that SSI. For example, in a hysterectomy, are you isolating vaginal cuff instruments? I mean, that's a huge, huge issue when you're looking at SSIs with a hysterectomy.
Okay, that's great. I think we're actually coming up to our hour's allocation, Deborah, so thank you so much for a really great and informative webinar. And also thanks once again to our sponsor, RebScrubs. Just a reminder that one lucky attendee today will win an Amazon gift card for completing the post-webinar survey, which will appear on your screen shortly. For more information on our upcoming OR Today webinars, please visit our website, ortoday.com/webinars. Thank you so much again for joining us today, and enjoy the rest of your day, and we hope to see you next month.